Dr. Sujit, would you like to share your slides?
Yeah, sure. Look, let me share it.
Thank you. That's very kind. We still just have 2 more minutes and then we'll make a start.
Yeah.
You can start, Dr. Sujit. Go for it, please.
Okay. Hello, everyone. So I'm going to present this case. So this is a term baby who was born by normal vaginal delivery with no risk factors for sepsis, was in the postnatal ward and was noticed to have intermittent tachypnea, which prompted the admission. And following admission, the baby was on non-invasive respiratory support, needing a little bit of oxygen. And I scanned this baby using a hockey stick probe at 8 Hertz at 4 hours of age. And so this is R1 and R2. So R1, so you're seeing sort of 2 intercostal spaces, bat sign. There is a nice sort of pleural line that you're seeing. It is moving and you can see A lines going through. So this looks like a well aerated lung. Same as for R2. So this is a bit more lower down again, thin pleural lines. You are seeing some comet tail artifacts, but you can clearly see pleural sliding and good A lines all throughout. Moving on to R3 and R4. So R3, again, thin pleural line, you can clearly see sliding and you're seeing A lines throughout. So the bamboo sign, you can call it. And then R4, again, the same. I mean, I'm losing out a little bit here. I don't know if it's probably because of poor contact, but it'd be nice to get it all the way there. But you're seeing clearly A lines. And then on the left side, so this is L1. Again, this is a nice thin pleural line, sliding is present, predominantly A lines. I suspect this may be the heart, I don't know.
Yeah, I agree. That's the heart. Yep.
Yeah. And then moving on to L, yeah, so this is a bit lower on L2, but essentially I'm seeing A lines.
Yep.
Mostly A lines.
Yep.
And then L3 and L4. So L3, nice pleural line, A lines all throughout. L4, so coming here, I'm seeing pleural lines there, and then I'm losing out. I'm seeing this area of dropout, and I'm seeing this sort of irregular margin.
Yep.
Which sort of appears like a shred sign. So I interrogated that area a bit more on the subsequent slide. So this is again, this is the same sort of longitudinal scanning. So you can see, to me, I don't know, after the last session, I wonder if this is dynamic air bronchograms that's coming in and out, don't know. But I can clearly see a shred sign. I then did transverse scanning. So there isn't any ribs that you can see. So you're clearly seeing a breach in the pleural line. And You can see this bit is sort of getting bright, and I don't know if that is a dynamic air bronchogram, but I can see sort of static air bronchograms. So clearly there is, and this bit down here is a dense B line, which I suspect may be a consolidation.
Yeah.
And the same goes here. We're again seeing this bit here, which makes me suspicious of a dynamic air bronchogram, and clearly I'm seeing dense B lines. So this baby then had a chest X-ray, and this is the area of interest.
Yeah. Yeah. Absolutely. Yeah.
And there was a slight rise in the inflammatory markers. Clinically, the baby was weaned off and finished off a course of IV antibiotics.
So a beautiful case. We'll just go back to your images, sir.
Yeah, yeah.
Very nice images, and I mean, it's the beauty of lung ultrasound again. So we just go back to the first image. So the first few, just R1. Yeah, let's write R1. Yep. Just go back a slide. So if we just play the images again. So again, so what you can see is sliding with comet tails. So kind of really reassuring once you see sliding that you can't have a pneumothorax. And that's important because you've got a dominant A profile with bamboo sign all the way through, but definite sliding. Always worth just doing your M mode over here as well. You might have already done it. And, you know, I might.
No, I didn't do it, Alok. I didn't do it. But yeah, and the reason you're saying that is just to make sure that you're seeing sort of a seashore sign.
Yeah. So the only reason again that I would like it done is because you just have a small truck sign in the middle. So you can see a rib. So just in the middle, right in the middle there.
Yeah.
So just you know, experience says, because I can see comet tails quite easily, I don't think we have any doubt. But it just adds to the value of the fact that, you know, you'll be storing the images. You can clearly demonstrate a seashore sign.
Yeah.
Very nice. And then R2 again. So I'd say the image quality is very good. You're using a hockey stick, you're using a low frequency. You often will have a small footprint. And because of the small footprint, the images are always a little bit on the grainy side. You know, I have the same problems, but beautiful images here. Bamboo sign, very nicely distributed. I mean, well aerated lung on the right side. Yeah. So in R3, you're losing a little bit of contact. It is the challenge of doing R3. I always have the same problem, and I'm going to show you some images today where I'm losing contact. And just getting somebody to abduct that right hand, always where possible, if the baby's stable, have a nurse abduct the right hand up so that you can get a nice image. But again, what I'd say is that you've got good pleural sliding, few comet tails, well aerated bamboo sign, and just a little bit of a smudged A line, because probably you've just got a slight issue with the angle of the probe not being 90, but beautiful image. I'm happy. See, again, what I'd say is, guys, we're not aiming for perfection. Perfection, the reason I say that is babies for different reasons. They might be vigorous, they might be active, it might be difficult. You might be doing it in a very acute situation. For me, what is very important is that you're able to make a good interpretation from the scan based on your clinical correlation. So we don't need perfect images. The other thing to highlight that is quite important when we're kind of doing scans is that, especially if you're acutely kind of distressed and you really want to make a diagnosis very quickly, you might not have as much time to image optimize. But for me, these scans are perfectly interpretable, very good. And I've got good depth on them. I can see an A line all the way down to nearly 3 centimeters on R3. R4, I can see them all the way down. You know, what you're having is image attenuation. So, and you're already using the lowest frequency, so we can't go any further down. So that's fine, not a problem. Yep. L2 is always a challenge with the heart, and I think you've done fantastically well. I must confess, L1. I've had a few struggles with L1 these days, and it's you know, for me, you've got really nice L1 there with the heart coming in. Again, A lines all the way through, comet tails, good sliding, no truck sign. So, you know, aerated lung, as is with L2. The heart coming in the way naturally because it's lower down. So I'm happy. Very nice images. Yeah, just on L2. There's just a point when you look in the middle where the pleura looks very bright, and you kind of lose out at the bottom. So the upper half looks bright, and the lower half looks a little bit. So just some people can sometimes confuse that with a lung point. It's not. It's heart. That's heart coming in the way. And really, yeah, again, what I'd say is where possible, always try and see if you can get your M mode on.
Okay.
Yeah. So very nice image. I mean, L3 is beautiful all the way through. You've got well aerated lung. And then the beauty of what you can't see on a chest X-ray clearly has come up very nicely over here. You've lost your pleura where you've got a very classical shred sign. That's because you have subpleural consolidation all the way through. It's completely through up to 4 centimeters with some atelectasis there, static bronchograms. And I completely agree, you've got some dynamic bronchogram that just coming in and out, which are more obvious on the other images. So I mean, for me, this is a very suspicious sign of a mnemonic consolidation. Did you want to do Dopplers?
No, so Alok, this was early on after I heard that talk. Next time I'm going to tackle the Dopplers if I come across. I haven't done. So that's one thing I've reflected on.
No, it's okay. No need. I mean, trust me. I mean, these images are beautiful. These are beautiful images. A very nice fractal shred sign. And this image, especially on the left side, you can see a very nice dynamic bronchogram going in and out.
This one.
Yeah, just there. Perfect. So, for me, again, what I'd say is you have dominant consolidation from 1.5 centimeters down. Then you've basically got an area of static air bronchograms. You lose your pleural margin and you have fractal sign. So, this is not atelectasis. This is the point I'd like to make, that just because you've lost your pleural margin there, this is fractal sign or shred sign, where basically the subalveolar space has been destroyed. Hence, you're not having aeration of the distal pleura. So this would be different from atelectasis. So, but very nice images. And then the X-ray more or less confirms, very nice. My congratulations.
Thank you so much. I'll stop sharing.
That's very kind, sir. I have, who have I got next? I've got Naz, Dr. Merchant.
Yep, I'll share my screen.
Just while Naz is sharing her screen, can I just say, guys, I know some of you have got cardiac probes. You don't have the linear, or you don't have the hockey stick. I would say don't feel worried or anxious or embarrassed about sharing your images. Please share them. You can scan with any probe. Image interpretation and clinical correlation is the key. So I would strongly encourage, don't worry and don't wait for your probes to come through. Just scan, share your images. The question from our perspective is a very good opportunity for us to be able to make diagnosis with, even curvilinear or sector probes. So please, Subhash, INR, please go for it. Don't feel worried at all. Go for it, Dr. Merchant.
So I'm Naz, I'm one of the neonatal consultants at Watford at London, UK. I use a GE scanner and I've got a 12 linear probe. So it's not that exciting, the case, but it was exciting for me because I diagnosed it before the X-ray. So it's a term baby, 40 weeks, 3.6 kilo baby, good weight. It was a Cat2 section for a prolonged second stage labor. Crash call because to the neonatal team because of minimal respiratory effort at birth and required inflation and ventilation breaths, and then facial PEEP to give CPAP basically, but required around 80 to 100% oxygen. So it was transferred to the neonatal unit, put on CPAP, and their FiO2 had come down by then to 40%. Baby was very active and vigorous. So my differential at this point was this is just a transitioning baby, perinatal adaptation, could be TTN, RDS, or even sepsis, but there was no risk factors for sepsis. So just at the transfer, while the nurses were putting the probes and lines and on, I decided to put the probe on. So this is on the R1. So nice thin pleural, but there's no pleural sliding at all.
Yep.
And got B lines all the way through over here. And then on R2 as well, very similar. Again, there's no lung sliding, and again, B lines all throughout. Sorry.
Yep.
So, and then on R3, okay, sorry, I don't know why I don't have R3. 3.
Not to worry.
On R4 as well. So here you can see the lungs sliding and the liver's coming down below, and lots of it's quite thick in pleura, and there are lots of D lines coming through as well. You can see some A lines as well. Yeah.
Yep.
And then, so I tried finding the lung point. And so between R1 and R3,
beautiful.
you can see
Absolutely
that the pleura is not moving over here. But then as you come towards the axilla on the side, you can see the pleura moving with nice B lines coming through over here. While very similar between R2 and R4 as well. Again, you can see the pleura not moving over here. So you got a nice lung point over there. And then lots of B lines coming down, and again, A lines as well. So AB profile in the R4, but R2.
Dr. Merchant, how old is the baby at this age?
Probably less than an hour old.
Less than an hour old. Okay.
So literally within I think probably half an hour, baby born and then came up to the unit. So between 30 minutes to an hour.
Sure.
And this is on the R5. Sorry, it's not very good scans because the baby then was getting quite active and vigorous, but you can see that the pleura was moving and there was more of an A profile actually over here, while R6 also very, very similar. Again, A profile over here, but pleura moving. They put the M mode on and you can see the barcode.
Yep, very nice. Beautiful.
And then even on the R2, there's a barcode, but when you reach R4, you start getting the C-store sign coming up. And I think, and then have only L2 and L3. I think I got too excited with the R's, right? Sorry. That you can see the pleura moving nicely on the left side, and you can see B lines coming down with A lines being present over here. So an AB profile. And then very, very similar over here. The heart shadow unfortunately comes in, but lots of pleura being moving, sliding, lots of it's an AB profile coming up there.
Very nice images. I mean, from my perspective, beautiful. Clinical correlation. You've got please carry on. Yeah, my apologies.
No, go ahead. Sorry, Alok.
No, I was just gonna say, you've got a small anterior pneumothorax is my impression, kind of heading towards R3. Beautiful lung point. Could we just go back to your images? We'll start right from the beginning.
That's the R1.
Yeah, so again, very, very nice images. So you've got an A profile. Again, for people who are confused, if you ever feel you're not sure, just put your M mode on and you'll get a barcode sign in this particular situation. Again, a really nice image to kind of say you don't always get truck sign, especially if there's just a small amount of anterior air. So beautiful image. And then if we just click on R2. So again, an A profile throughout. Yeah, very difficult. I'm not really convinced I can see sliding there. So very, very nice. No comments. You've got depth all the way through, so.
I think I'm losing some around after this point.
What's your frequency at that point?
10 hertz.
10. You can come down a little bit. It's a term baby. So you can come down to about 9, even try 8. So, and that gives you a little bit better depth penetration. And then my only other thought is if you do want to see a little bit deeper, you can bring your focus down because your focus is at the pleural margin.
Yeah.
But otherwise, for me, this is beautiful. Yeah, very nice.
Okay.
Yeah, classically very wet lungs. As you start moving to the more dependent parts, you've got a B profile, kind of with dominant B profile. You've got one big A line in the middle with the liver coming in, and then a big acoustic shadow from a rib below that. But looks easily interpretable at this particular point, transitioning kind of lung. So, yep. And this is basically your lung point. It's beautiful. You can see very nicely the pleura moving. You can see the difference between the A and the kind of complete B profile, which is Corley's B lines. So very nice. And R1, R3 basically indicates you've got anterior air. Once you kind of hit, what is nice is to help quantify your pneumothorax. It's kind of moving across to try and see where it actually stops. And if it's at anterior axillary line, then that's a small anterior pneumothorax. But if it extends to the posterior axillary line, experience says that's decent. And if if it extends beyond that, then you usually can't trace the lung point if the baby is actually supine. So what I'd say is that if you can't trace the lung point, that's a decent sized pneumothorax. Just for everybody, just to be aware, what sometimes we do is we want to look at R5 and R6, and we put the baby in the left lateral position to see R5 and R6. Just remember, your air will come superiorly. And in that particular point, you will then see a lung point that's even further back. So the best way to kind of analyze how large your pneumothorax is, if the baby's in supine position, try to trace, and experience says rather than trying to move the baby, and this is what I'm going to talk about today, try and see if you can actually look at the posterior axillary line to see your posterior lungs. And that means you don't have to move the baby at all. But yeah, very nice images. I mean, as you're progressing, there's very little for me to critique, to be honest. Naturally, R5, R6, always challenging. Did you do them with the baby supine?
No, so these initial ones, I did it supine, and then we did an X-ray, and then for the baby prone. Yeah. So this is slightly later, and so the baby was prone for 15 minutes.
That's fine. That's fine. That's fine. Looks nice. A little bit more depth. Might have to lower the frequency. So just at the back, you have more muscle and tissue, and the scapula often intervenes. So you have to go in the middle of the scapula, and you might just want to, when you increase your depth, drop your frequency just a bit to get a better image, especially at the back where there's thicker tissue. But yeah, very nice. I can see it all the way down. You've got an A profile, not much in terms of B lines seen at all. So well aerated lung. For pleural sliding, my only question here is, it's a little bit tricky. And I would, because you're prone at this particular point, I'd probably put some M mode on. Did you manage to put an M mode on?
Yeah. No, I didn't put an M mode on at the back.
Yep. Just, it's a little bit tricky. I would say that you might have some air there. You might not. I can't see any B lines. Maybe the odd B line in the middle, but always, if you're confused, just put your M mode on. What would normally happen is anterior air would come posteriorly when you're prone. So there is just a possibility there that you might have a small bubble, which is basically moved at the back. But when I look at R6, I'm convinced that I can definitely see sliding. Absolutely no doubt about it. Even some comet tail signs. So R6, I have no doubt too. But beautiful images, Dr. Marchant. I would not be able to get better myself. And a very nice barcode sign. I think this is one for you to keep for teaching. You can use them. They're beautiful images. My compliments. Do you have another case?
Sorry, Alok, can I have a quick question? You mentioned about the extension, like to monitor the extension or to appreciate the extension of the pneumothorax, how much it's big. What did you recommend? Is it like tracing if the baby is in supine position, as you said?
Yeah, can you see me?
Yes.
So basically my probe, when I'm looking at an anterior pneumothorax, this is R1, this is R2, this is R3, this is R4, R5, R6 at the back. Now air when you're supine will be anterior. Yeah. Now the more the air accumulates, basically the pocket will move so that it's more lateral. And if you have a tension pneumothorax, basically the lung is completely collapsed. So you'll have air everywhere. And if you went through the posterior axillary line, you'd also see air over there. So what I like to do to trace the lung point is move my probe like this and really try and see where I can see the lung point coming through with pleural sliding and no pleural sliding. And that will tell me. So if I'm moving across and I kind of hit R3, just always remember that small anterior pneumothoraces, again, if your baby, and a lot of people like to keep the head end elevated. So if your head end is elevated, then the air will be predominantly up and anterior. Whereas if you're supine, it might actually be the entire anterior part of the chest.
Yeah.
So what I'd say is that a lung point can be seen here and here. But experience says if you're supine and it's a decent pneumothorax, just move laterally and try and chase from your perspective exactly where you see the pleural sliding coming through. Now, if you're in the posterior axillary line and you can't see pleural sliding, that's a significant pneumothorax.
Yeah.
And clinically, from my perspective, what I'd say is that if you're in the posterior axillary line and you can't see a lung point, then that's got to be a decent sized pneumothorax. And I'd be surprised if your baby is not symptomatic. So that's how you kind of grade the pneumothorax. There are no formulas, and none that I know, that actually quantify how much air. Pleural effusions are a different kettle of fish, and we'll discuss them at the kind of next session. But here I would say that go clinically. This is very, very important. And always just remember, with a pneumothorax, you're doing a lung ultrasound at one point of time. We're going to see some cases today. And really what I'd say to you is accumulation of a pneumothorax and it getting worse can happen within a minute. You might do a lung ultrasound now where the pneumothorax is actually small and just starting out, especially ventilated. And within 10 minutes, you might find that you're not able to saturate and your pulses are weak. So please always clinically correlate. And a very big take-home message from my talk today will be, you must reassess if things are not going well. So, please always do that. Do you have another case, Dr. Merchant?
No, I thought
no problems. Yeah, that's fine. That's fine. Not a problem. Beautiful case. We learn all the time. So I have got Dr. Iambo, Doris.
Sorry, I was still muted. Okay, let me share my screen. Is it all right? I have two cases.
Sure. We have time today because the presentation is not going to be so long. So we can.
Okay. Cool. So I'll start with the first one. Okay, so the first case, this was a 38-week birth weight of 3.64 kilograms, was born by elective cesarean section with a background of a history of previous cesarean section. There were no risk factors for sepsis. Mom had gestational diabetes and was managed with metformin. And so the history was after birth. Baby was born in good condition, but was noted to be grunting at 11 hours of age. So in view of that, he was transferred to the neonatal unit, admitted, started on high flow, nasal cannula oxygen. But as his work of breathing persisted and got worse, the team decided to give him Curacef, which they did. And in spite of that, he was still quite tachypneic, quite a big chunky baby. So was honestly still tachypneic. And he was changed from high flow to CPAP. And at the time I did his ultrasound, he was CPAP in air. But I particularly did it because he was so tachypneic. And so I decided to do the long ultrasound. So he had two x-rays, which I'll show. And the team were querying maybe or not, maybe there's a pneumothorax, maybe or maybe not. So I was very happy to do this ultrasound. So I tried my best to adjust the settings.
Don't worry.
The depth to 4, and I couldn't change the gain. So this is a baby's x-ray. So the first x-ray on admission, as you can see on the left, and after 24 hours, the second x-ray. So baby was still quite tachypneic, and at handover, the team were not entirely sure whether baby did have a pneumothorax. So I did the ultrasound.
Can I just one question? Just with the nasogastric tube, did they have any difficulty with insertion?
No.
In the first image, just because it's quite high?
Yeah, but in the subsequent x-rays, they had pushed it in, as you can see.
Sure, so it's been pushed in.
It was pushed in.
Fine. Yeah.
So the second x-ray at 24 hours, you can see it was in the stomach.
Sure. Thank you.
So, yeah, so I actually started, baby was prone when I started. So I started with the back. And then after doing those ultrasounds, I turned him supine. So I'll show the x-rays of his back, the ultrasound of his back later. So this is R1. So I started, and as you can see, the pleural is thin, smooth, and regular. And I only saw A lines. I couldn't see any B lines. And I couldn't see pleural sliding. And
Yeah.
I know there's a dropout.
Possibly a lung pulse. Yeah.
Yeah, so it looks like a lung pulse. And I tried, I think I used so much gel in a bit to make this image better, but it looked better on the monitor. So no pleural site sliding, no B lines, and definitely an A profile. L2, so I moved down to L2, and with L2, I could see the pleural still looks continuous. On the right side, you can see B line, and on the left side, only A lines. So pleural sliding on the right, no pleural sliding on the left. So I put that down as this was my long point. And I think I said there are more A lines than B lines. So I wasn't sure whether it was an AB profile. I should just say an A profile.
It's an A profile in R2 all the way to the bottom. It's very tricky. You've got a rib there. And you did definitely have a B line. So whether was your baby elevated? So this is prone position or supine?
This is supine. I had turned the baby supine.
Head end elevated?
Do you know what? I don't remember. I didn't check.
No problems. That's okay. Don't worry. Yeah. So possibly you've got a lung point anteriorly between the upper and lower parts. Yeah, that's fine.
And that's R2. Yeah. So I put the M mode on. So R1, I could appreciate the barcode.
Very nice.
Then R2, because I knew there was a long point there. So this is the barcode because I kept comparing whether it looked the same. So I think this is the barcode sign too.
It is the barcode sign. So if you look at the cursor and where you've kept it in R2, this is all along the A- profile.
Yeah.
So really, in order to get the lung point, what you've got to do is you've got to move this cursor to the right so that you come to the junction between the A and the B profile. And that will then give you the transition from barcode sign to seashore sign.
Okay, yeah. Well, anyway, I could see that clearly. And so R3, and so this is R3. So even with R3, I could clearly see the bath wing sign. The pleural is thin, continuous. Do you know what? I was wondering, I think there is pleural sliding.
Yeah, I would agree.
Yeah,
and if any confusion, just put your M mode on. But I think there is. Yeah, I think there is.
Yeah, and then I was wondering if these are subpleural consolidations just below the pleural line, and then these areas. I was wondering whether they were air bronchograms.
I don't think so. I think you've got a little bit of a grainy image there, and it's typically the problem that you have with R3 high up. And again, I would say, please get a nurse to extend your arm so that you can keep your probe completely perpendicular. And I'm not, whether you might have a consolidation there is tricky. It's very difficult. My gut feeling is that it just looks like aerated lung to me. And I think you've just got a little bit of artifact there because of you not being completely 90. My feeling is I wouldn't say there's subpleural consolidations.
Okay.
Yeah.
And this is clearly an A profile.
Yeah.
Okay. So R4. So R4, I could appreciate the pleural was continuous. It looks a little bit irregular. There are few B lines, as we can see, and comet tails, and there is pleural sliding. But you still see mainly A lines. This is an A profile. So R5. So now I had started with R5 and R6 because baby was prone when I started. Yeah. So this was the first one I did, and I, was not initially. I wasn't sure whether there was pleural sliding, or this was the long pulse. You can see the pleural clearly, but I wasn't sure whether there was pleural sliding. Honestly, I'm not sure whether there was pleural sliding. I had started with this, so I should have put the M mode here, but I had already done the baby and I didn't want to go back again. But you can see A lines. I couldn't see any B lines.
Yep, you have an A profile. I'm not convinced you have any B lines, but here you might have some subpleural consolidation.
Yeah.
Just those two right regions. That's interesting.
Yeah. And here,
Yeah. So what was the mode of delivery?
It was cesarean section. It was
elective,
elective because of a history of previous cesarean section. Mom ruptured membranes, and because of the previous history and breech presentation, they just went ahead and did an elective, well, semi-elective cesarean section. Yeah. And R6 also, the same thing. I could see the pleura. I could see A lines. I don't know whether there's very few B lines, or comet tails. I took a while trying to look for them. Or this is just mainly A lines that I could see.
My gut feeling again is, I'm not convinced you have any B lines.
Yeah.
You've lost a lot of depth there. Yeah. You're using a frequency of 7?
Yes, I use the frequency of 7. I tried going higher, going lower, but it wasn't working. So I just
my advice would be, you're worried about a pneumothorax with a baby in prone position. So don't hesitate in that situation to reduce your depth, to focus on the superficial areas of the lung. And then when you want to look at the deeper areas of the lung, then increase your depth. I'm not sure you'd be able to use a frequency lower than that. So it's a little bit unusual as to why you can't put the gain up as well. So which machine are you using?
It's a GE machine, but I couldn't find a button, or because it's preset. I used the hockey stick, so it just showed as it was preset. I kept turning all the.
So what you need to do on the GA machine is, once you use the preset, you can't adjust anything.
Yeah.
So what I would suggest is, if you're using a hockey stick, you go into the preset. There's a frequency button in the middle.
Okay.
So you have to press the frequency button and keep it pressed down. And when you keep it pressed down, it allows you then to alter settings, because it takes you out of the preset.
Okay.
Yeah. So try that. That lets you change frequency as well.
Okay.
And the other thing then is, you can actually alter gain. Do you have an auto gain function?
I do. I don't know. I couldn't see any button, but there's a button that says auto, and it said.
Yeah, that's the one. That's the one that you have to press, and that will automatically change your gain. But you must have contact. You must have contact. So good contact with good gel. So do me a favor, Doris. Send me a screenshot. PM me tomorrow, just of your motherboard.
Okay.
And then
yeah. I'll do that. Yeah.
Yep. Carry on.
Yeah. So L1. Yeah. So with L1, you can see the pleural. It is continuous, a little bit grainy, but it is continuous. There is pleural sliding, and you can
definitely
see
100%.
B lines, very few B lines, and A lines also. And I could also appreciate comet tails, clearly an A profile. L2. This is L2. No, sorry. What did I do? I've gone back. Sorry. Yeah. So L2, also pleural sliding, continuous pleural line. It looks irregular, but it is continuous. You can appreciate B lines and also A lines. And I think this is an AB profile.
Yep. Got the heart coming in there. Yep.
Yeah. And L3, the same thing.
Lung point.
Long point.
Double lung point. My apologies.
Double long point. Yeah, I saw that, but that's why I put query whether it was actually a double long point. Yeah.
It's a double lung point. No doubt about it. Yeah.
All right. Yeah. So we can appreciate that clearly. Lots of comet tails. Are there air bronchograms? Because I was wondering whether these.
No. My feeling is, and again, this is where I'd say that the subpleural consolidations that we kind of get confused with, these are very small. They're less than 5 millimeters. For me, again, clinically, I think this goes more in favor of transient tachypnea of the newborn with transitioning lung. And you've obviously developed a pneumothorax in this baby, which is still persisting. I would say, the only evidence of subpleural consolidation is those 2 regions that we saw posteriorly.
Yeah.
And for me, again, what I'd say is, you sometimes have a little bit of a kind of a mix of both, which Nadia has kind of commented on. But I think clinically, no doubt, my clinical feeling at the moment is you probably have got TTN. I'm not really convinced you've got air bronchograms anywhere.
Okay.
Yeah. Just one comment. Your preset settings definitely need to be changed.
I don't know. I don't know how to change them.
Send me your motherboard. And what we can do is when you're at work one day and you have the machine, we can go through it. So the best way to get in touch with me is bottom. So I'll send you the link.
Okay.
We can have a look at your machine and I can show you how to do the presets.
Okay, that would be fine. Yeah. So this is L4.
Yeah.
You can appreciate the plural sliding, comet tilts, B lines and A lines. I think this is more of an AB profile. So L5 and L6, you can appreciate the plural being continuous, plural sliding, comet tails, B lines, and also A lines. And I think I put this down as an AB profile.
Yeah.
Right? Okay.
Yeah. Double lung points.
Yeah.
Both sides. Yeah. You've obviously got, yeah. You do have, it's a little bit tricky. And again, what I'd say is you're losing a little bit of contact posteriorly, which means the top half of your image is giving you those images that look like subpleural consolidations. And really, because you're using a hockey stick, that's the challenge with using a hockey stick in really big term babies. You tend to lose contact.
Yeah.
A linear probe, if you have one, is beautiful and a much better way to look at a big term baby. But I think, for me, looking at these images clinically, you never gave this baby surfactant, did you?
No, initially they gave surfactant. So I gave surfactant, within the first, 8 hours. I did a long ultrasound, 36 hours.
Okay. It would have been interesting to see whether you had subpleural consolidations than before, because again, that would and that's the beauty of lung ultrasound if you can do it serially, because you lose evidence whether you've had subpleural consolidations early on, and now you're kind of 2 days into it. But no doubt about the pneumothorax, absolutely no doubt. Yeah.
I was quite pleased that I picked that up, and I was confident to say that, that there was a pneumothorax. L6, so with L6, you can clearly see pleural sliding. The pleural is continuous, A lines, comet tails, B lines. I don't know if this...
I just wonder whether that could be subpleural consolidation again, which is a little bit more dense, as I wouldn't call them static air bronchograms. For me, the question is whether there's a little bit of an alveologram there.
Okay.
Again, what I'd say is you just need to move your probe a little bit, get a little bit more contact. And if that disappears and the pleural line looks completely clean, then you know that contact is the issue. But if it persists, then really that would be a subpleural consolidation.
Okay.
As you can see in both the L5 images.
Yeah. Anyway, after I did a long ultrasound, baby was in air, saturating well, but was very tachypneic. So I just increased the oxygen to 30%, managed conservatively, and by the next day, the baby had improved. And as at overnight, we're within the FiO2. In fact, it's back to air now, less tachypneic.
Sure.
Stable. Yeah.
That's great. What I'm going to say is, Doris, just because Sharif wants to present as well, and we have time for 2 more, is it okay if I let Kirti go? So we're going to have peer review again on Tuesday. So if you want to go first on Tuesday with your next case.
Okay.
I'm really grateful. Thank you so much. So beautiful cases. We've seen pneumonias. We've seen 2 pneumothoraces. Really nice kind of barcode signs on the pneumothoraces. So Kirti, are you happy to share?
Yes, 1 second.
Thank you. I'm really grateful.
So this is a baby who was born at 27 weeks with a birth weight of 800 grams and was now 5 weeks old with a corrected gestation age of 32 weeks. Just a brief background, this baby had pulmonary hemorrhage, then received postnatal steroids and was now on NIPPV. The reason I did this scan was because there was worsening respiratory status. I used a linear probe and the maximum frequency I have is 8 Hertz. I tried this auto gain and sharp modes. And because my probe is so big, I can only capture anterior, lateral, and posterior.
That's okay. That's beautiful. I love using a linear probe. Trust me, it's my I don't like using the hockey stick except in extremely preterm babies and preterm babies under 1500 grams. Yeah. Wow. Oh dear. Okay.
This is the right anterior, which I think is pleural line is thickened and broken. No A lines, alveolar interstitial pattern with micro consolidations, maybe here. And this here is the shred sign, which with static bronchograph is what I thought. And when I did a Doppler on this, could it be that this vascularity is more of the surrounding area and not within the area?
It's non-specific. So if you remember the image that I showed you last time, basically what you'll have is the appearance of blood vessels within that area. This is more kind of what I'd say is, the word I use is basically a pulsatile Doppler, where you've got red with blue, but no specificity to it. So for me, that's not increased vascularity. The pleura is, completely irregular, destroyed. You just want to play the image without the Doppler.
This one?
Yes, please. That's really kind. So what I'd say is you definitely have what looks like an area of breakdown. Yeah. Yeah. And you've concentrated and you don't have any focal vessels over there. For me, this is now what people kind of describe as a snowflake kind of an appearance, as opposed to a really obvious fractal or a shred sign.
Okay.
Yeah. So some people also call this debris sign with chronic lung disease. So that's the way Dr. Wang in China would describe it. So it's not a really classical fractal sign. It's because you don't have a typical crater with the pleura. Now here, absolutely no doubt, you've got a fractal sign. Please go ahead and you can describe the images. Yeah.
What did you say was the sign? Snowflake?
It's called debris sign. It's called debris sign, or some people like to use the terminology snowflake sign. It's like snowflakes.
But
snow falling down.
Here, because you said it was for RDS.
You're right. You're right. I would probably use Dr. Wang's terminology and call it debris sign, but I wouldn't classically say that's a classical fractal sign. So when I look at this image, for me, chronic lung disease BPD is standing out really high at this particular point because you've got massive numbers of micro consolidations all the way through. Is your CRP elevated?
No, just 15.
Well, that's elevated. That's interesting. Yeah, beautiful.
This is the right lateral area with absent pleural line. There are no A lines, AIS pattern, shred sign. With
beautiful. Yeah, absolutely beautiful shred sign. Sorry, not good for the baby, but can you see the blood vessels?
Yes. So
amazing. So
there's increased vascularity. Then in the posterior area, there's just continuous pleural line, though a bit thickened. No clear A lines, and then AIS pattern.
Yep.
On the left posterior, there are still some few A lines here and there in between with an AIS pattern.
Yep.
This is left anterior. So this continuous line absent on the right here. Is this also going to be a debris sign then?
Not quite. No, this is basically just a completely destroyed pleura with what is very thickened pleura and subpleural kind of consolidations, micro consolidations.
Okay, so
it does look like more like my personal view, I'd like to call it a kind of a snowflake sign.
Okay.
But yeah, Dr. Jing Liu would probably get very upset if I use that terminology. I just wonder whether you've also got some static air bronchograms right at the bottom. So a little bit higher, go a little there. Okay. So can you see them? So they disappear and appear just there. So you definitely have very thick destroyed pleura, a complete, I would say, B profile with white lung. Basically, subpleural consolidations. The pleura is sliding. Yep.
Yes.
Yeah. I mean, it's trust me to say, your images are very nice. With the frequency you're using, you're getting depth all the way through. These are beautiful images.
Thank you. I thought they weren't very good.
No, not at all. Absolutely beautiful images.
And then on the left lateral side, again, the pleural line is absent, and in some areas here, it's thickened. Then no clear A lines, AIS pattern. Can we call this a shred sign then, or no? Or more of micro-consolidation?
Yeah, more of micro-consolidations, not quite evolved into a proper shred sign. I wouldn't be surprised if it does. So I think more of micro-consolidations throughout. And just if you move to the right of your screen, you have a small area that looks loosened below a rib. So if you just take your arrow to that, lower, there. That's a rib shadow. That's not a shred sign. So just go up. You have this hole. That's not a shred sign. That's a rib shadow. Okay. Yeah, the pleura is irregular, but I just think you've got a significant. So, I mean, for me, this is again lots of micro-consolidations with a complete whiteout kind of lung pattern. Really bad chronic lung disease.
So my impression on lung ultrasound was bilateral alveolar interstitial pattern with atelectasis in the anterior lateral areas and an area of consolidation on the right lateral zone.
Possibly a pneumonia, yeah.
This was the X-ray with reticular pattern bilaterally.
Yeah. And again, this is the beauty of lung ultrasound. This X-ray doesn't tell you a lot.
Yeah.
You know what if for your baby, it basically has evolving lung disease. But can you see how with the right lateral zone, I mean, you've got an obvious fractal sign with a CRP of 15. My gut feeling is you've probably got consolidation in this zone, which is probably harboring infection. Have you cultured ET secretions? Are you growing anything?
We didn't culture this time, but the last time we did it was negative.
Okay. Beautiful images. I have.
Thank you.
Yeah, no critique. I think I get a really good feel.
Thank you.
Sorry, can I ask a question? Well done, Kitty. At the LA scan, the view, was that the heart coming into view?
Yes.
Yeah,
that is correct.
All right, well done, Kitty.
Thank you.
I'm going to show you my struggles with basically the heart today. We've had some beautiful cases. Dr. Sharif will go next.
Can I share my screen now?
Go for it, sir.
Thank you.
Beautiful cases today, guys. I'm really grateful to all of you. Yeah. You guys have done a fantastic job.
Thank you. Can you see my screen?
We can. You just have to go into slideshow mode. Yeah. Thank you. Right. God bless you.
No problem. So this is a preterm baby, 27 weeks, with a birth weight of 970 grams. The baby was had one dose of, mom had one dose of steroids and magnesium sulfate, quick delivery, and the baby just needed high flow nasal cannula. So basically, we haven't done an X-ray soon after birth, and the baby was in 21% of high flow of 6 liters and was absolutely well from the clinical perspective. Only we started antibiotics because of the premature delivery and early jaundice. So the reason I did the ultrasound was basically for training rather than anything else. But I will show you something that I was really confused about. So that was R1. Mm-hmm. In R1, I can see that firstly, I'm using the linear probe, and I use a frequency of 8. So from what I can see here, the pleura is slightly irregular. There is a pleural sliding. There's common B tails. It's a dominant A profile. I can also see some mirror image or truck sign, and I can see also some confluent B lines on the left side of the slide, but it's mainly A profile. And then, yes, I just put the M mode.
Yep.
And on the M mode, I found on the left side, I will try to get my laser pointer here. I was suspected this part is a barcode, while this part is more of seashore sign.
Okay. So it's a beautiful case. It's an absolutely beautiful case. Can we go back to your image?
Yeah, sure.
Okay. So can we play the image?
Yeah. Sorry, just 1 second.
Yeah, no problems. Take your time, sir.
I'm trying to go to just to remove the laser point.
Sure.
Okay. Sorry, how to cancel the laser? Just to go to the cursor, no matter.
So you're on the cursor. You've canceled the laser pointer. Just go back to the previous slide. Just go back to the previous slide, the one before this. Yeah.
Yeah.
No. The one before this.
Yeah. This is the first one. Yeah.
Yep. Okay. Now you've got the laser pointer on.
Yeah.
So you won't be able to play the image.
No, I need to remove. Sorry, I need to remove.
That's okay. Don't worry. Take your time. So if you
right
click.
Yeah. Mouse. Right click, yes.
So, yep. Pointer options. Then just click on laser pointer. Just click it. Beautiful.
Oh yeah.
Yeah.
Thank you.
Okay, so guys,
this is the first one.
Yeah. So, okay, guys, I would like to put this out to the group, guys. Can somebody else describe this, please? So everybody has to have a vote. So I only want you to concentrate on the superficial part, the pleural line and the subpleural area. Anybody else want to have a go?
Yes, I can try.
Okay, go for it.
So I can see the pleural. I can see comet tails. And I can see A lines.
Yeah.
It's towards the right of the screen. It's difficult to really see any B lines there, maybe because the image is grainy. It's actually difficult, but I can see comet tails towards the left, going towards the left of the screen.
So I would agree that the majority, 80% of the left of the screen, you can see comet tails. And then just in the region of the liver, when the liver comes into view, the real question is that pleura sliding or not? So what do we think, guys? Do we think they're sliding there?
It looks more like a pulse, a lung pulse. It's bouncing up and down.
So my gut feeling, if you look at the margin, and I wish I had a laser pointer. So can
Shall I can you see my?
So I can see your cursor. So I want you to go to the liver. I want you to go to the liver right at the top. Right at the top. Yeah, just no. Just below the margin of the liver. There. Now just move left 1 centimeter. Left 1 more centimeter. 1 more centimeter. Now, if you look at the pleura here, for me, I don't think that's pulse. I think that's sliding.
Yeah,
I think that's sliding.
Yeah.
I think that's sliding. So my feeling is you've got comet tails pretty much all the way through. And I think there's lung sliding all the way through there.
Yes.
Okay. Now, can we go to the next slide where you see a barcode sign? So let's have a look. So when you see your cursor,
yeah, it's here.
Yeah, it's there. Now, my only worry is the pleura to the left of that is very irregular. The pleura to the right of that is very bright. So let's just play that again.
Here, you mean here? Exactly.
Yeah. Yep. Now let's. Have you taken another image?
Yes, I did.
Lovely. So just in the region, of the A profile.
Yeah.
That definitely looks like a barcode sign to me. Absolutely, yes. No doubt.
So what happened, Alok? I was really confused by the time, like the way, because I had the feeling that this is pleural sliding. In the previous image, I can see some common details, but down there, I can see some some barcode sign.
Yeah.
And also,
there are two things that I really want the group to take home as a message. Now, For me, I think you do have a small anterior pneumothorax in the R2 region. Now, whether your baby, and like if your baby is supine and the baby is head down, you have a little bit of a tilt, then the air will basically move up. Because I think the question you're asking me is, why haven't you got a collection in R1 and why do you have it in R2?
Yes.
Now, can I just ask, was the head end low?
The head was up. The head was slightly up.
Okay, it's a little bit of an unusual kind of a presentation there.
Yeah.
But you have an anterior, very small anterior bubble would be my feeling.
Yeah.
Now, what I'd say is that what is very important is that you've not lost contact. So you remember when Abhijit showed us the image, if you lose contact or if there's a lack of gel, then what happens is it defaults to a barcode setting. And if in particular, when you're using a linear probe, can you see my phone? Wait, can you see my phone? Just if you look at me.
Yes, I can see.
So when I'm putting the probe like this, especially a linear probe, and there's gel on the top half, but no gel on the bottom half, then that can give you a false positive barcode sign because you don't have any gel, no contact. So you have no ultrasound waves going through. So you get the barcode sign below, which is what you get if you keep the probe here off the chest, and you get a seashore sign because you have good contact. So just everybody, if you're confused about it, it's really important that you continue to make sure you have good contact. And I've had exactly this problem with a baby on my unit on Saturday. On Friday, who I was scanning, exactly the same problem that you're having. And my simple issue there was I was using the hockey stick in a term baby and I just did not have good contact. And as soon as I put gel and I had good contact, basically, but my feeling at the moment is this does in R2 looks like an anterior bubble. You've got an A profile with a kind of a bamboo sign and you've got a barcode sign.
Yes.
So it would have been very interesting to see the chest X-ray. Did you have a chest X-ray?
I'll tell you this. Unfortunately, I have it, but I can't share it. Maybe I get it next time.
No.
The reason why, because I went clinically. I will show you the rest of the scan. I went clinically, and the baby was very comfortable. So I have decided I'm not going for the chest X-ray. The baby is clinically well. What happened next day? The baby got aspirates from the NG tube, and then they needed to just do an X-ray just to see the nasogastric tube position, which was slightly deep. So, and the X-ray, I had a look, it looked like a very mild, like kind of RDS, but very, very mild. There was no pneumothorax.
Okay.
So I believe that your point of having like loss of contact is very important. I can't remember, to be honest, if I put a gel the whole way through the linear probe or no, but it was a bit of mystery about going there, but I will bring the X-ray.
My point against the loss of contact here is you've got a pleural line with A profile below it. So if you've lost contact, you'll basically lose a lot of your image quality. It'll appear dark. So you don't. So which is why I still think you probably have an anterior bubble.
Okay. And do you agree with me? This part is moving, right? This part is sliding.
It's a few of us in the group think that's lung pulse. It could be. Okay. It could be.
Yeah.
It could be. And that's why I'd say that the smallest air leaks is often the trickiest. We'll see a few more cases soon, but please carry on. Yeah.
Yeah. So this is R2. I repeat, I was continuing doing it, changing the gain and trying to see, because initially the pleura was irregular. So this is again R2. Here I could see also some like this was I can see some common details here on the right.
I can, and that again raises the the question is we haven't really lost sliding. You've got comet details that are moving. I can see them. So
I said that this is definitely slide. Then I put again the M mode. I could see also here on the middle. I can see that clear barcode sign, like here.
Yet you do have some T lines in between, which are lung pulse as well. I would agree that it does look like a barcode sign.
Yeah.
So it's one of those scans where you might have a small amount of anterior air or a bubble that's there. And really, it's not significant. It's not a very large amount. But such a small amount of air can resolve within an hour or two. So,
and then I move to R3 here. In R3, I can see the its dominant A profile. There is a regular pleura.
Definitely sliding. Definitely sliding.
Definitely sliding here.
No doubt about it. Yeah.
Yeah. It's mainly A profile, but it's and I got another image for it. Yeah, it's definitely sliding, but I couldn't see any B lines or common B tails. But I could see pleural. No, unfortunately, I didn't put M mode here. Okay. I went to the left side again. So I can see here common B tails.
Yeah.
Pleura is sliding. Maybe I can see here it's related to the lung point. Sorry, not the lung point, like the lung pulsation.
Yep, that's
and it's very close to the heart.
Yes, no doubt. Sujit, you have a question? Sorry, you've been waiting for a bit. Sorry.
Yeah, no, Alok. So Sharif, if you just go to R1, if you just go back to R1, I had a question.
Yeah.
So so just no. If you just go to R2 again.
This one or this one?
The next one. Yeah, and if you just play this. So my question was, when you look at the image, you can see in the top sort of 0.5 centimeter. Is it because the extremes of the probe is not touching the skin that you have a bit of jelly and you're seeing like that sort of, like a barcode right on top, not where the tissue is.
Yeah, you're right. My only other comment is I can't see a batwing sign. So, I can't see the ribs. And hence my worry that there might be contact as an issue here.
Oh, okay.
It's a little bit tricky without doing the scan yourself. It's very tricky. These are the ones where really you have to be doing the scan yourself. But my only other worry about this image is I can't see the ribs with, spaces in between. So again, loss of contact is a possibility, or just lack of gel.
Okay.
Thank you.
My pleasure.
So
yeah, very nice images. Again, what I'd say is your gain settings, they're just slightly on the higher side, Sharif.
Yes.
So, last few images that we saw, were you able to adjust your gain settings down? Are you able to do that?
Yes, I do.
Time gain comp. So it's worth just trying to see. And do you have an auto function or a I gain function?
It's GE. It's gain function. Yes, I can.
So G will have an auto on it, which you can press, which will take it down. But yeah, good depth. You're losing a little bit of 3 centimeters. What frequency are you using?
Frequency of 8.
Okay, that's fine. That's fine. One of the kind of ways of trying to alleviate that is basically trying, from our perspective, to reduce your depth. And then what I'd say is it reduces the footprint as well. You're using a hockey stick, right? Or a linear probe?
No, linear probe.
This is a linear probe. So why am I losing out on the ribs here? Are you zooming in? You're not zoomed in, are you?
No, I'm not zooming in. But you're right. I know that this scan, like if I show you other scans done by the same probe, you can see easily the ribs. But I'm not sure why you're right. In this scan, you can't see the ribs.
Okay, no worries. I mean, food for thought. Let's see when you do the scans again. Let's try and see if we can get the batwing sign with your. Just the question is whether we need to change your settings a little bit. And again, could you send me a picture of your motherboard? Just
okay. Yeah, sure.
Just private PM me on the WhatsApp so that I can have a look at it.
Okay. Yeah. Okay. Fine.
Yep. Carry on.
So again, this is L1. I can see pleural slides, common details. I can see in almost all the slide from upper to lower part. But again, when I put the M mode, I can see like a barcode sign, which is this is the same like on the left side. And this baby hasn't had any inflation or ventilation breath. So it was a bit confusing. And then
how old is your probe, Sharif? Is it a very old probe? No, the probe.
It's not new one, but in
5 years?
Yes, I think about that. But you know, in other scans, like because I'm scanning lots of babies now, and I couldn't have the same problem because I routinely put whenever
here I can see ribs, I can see them.
Yeah.
But for a term baby, they should be nicely ossified. I just let's have a play with your settings. Again, we can arrange a bottom call, and I mean on Wednesday, Doris and Sharif, I will be on the unit and I'll be on call in my unit, and I've got a GE machine. So we can maybe, if we look at a good, because both of you are based in the UK, I can actually take you live through my machine to try and see how we optimize your settings.
Yeah.
Thank you.
Sure. Thank you.
It's a little bit tricky to interpret at this particular point with these settings, but looks like a dominant A profile, maybe with some comet tails, heart coming in between. Yep.
Yeah.
And definitely ribs now visible, but normally they should be nice and ossified. You should see them as really dark shadows.
Yeah.
So the image is very grainy, and that's why I worry that, you know, you've got thymus coming in there with L1 at the top, is my feeling, but it actually nearly looks like tissue sign. So we probably really need to have a play, and then you have the heart at the bottom, but your A lines again, they're completely broken up.
Yeah.
So it's a very grainy image. So we probably need to have a really good play with your machine.
Okay.
Yeah, well aerated lung. Yep.
Yeah, well aerated lung, and that was the L3 at the end. You can see pleural sliding. It's mainly a profile, some common details here. But maybe here I couldn't get despite using frequency of 8.
Yep.
Yes. Thank you.
So you just, for those of you who've never seen Z lines before, can you see that on the right side? There's a big column that moves up and down. These are basically horizontal. This is what is classically called a Z line. It's not a B line. Yeah, it's a Z line. It gets wider as you move down. And it does not, can you see how it doesn't take its origin from the pleura? There's no contact with the pleura at all. It's broken down.
Yeah.
So this is classically what we call a Z line. It's a pseudo B line mimic.
What's the significance of it?
Nothing. It's just it's a B line mimic. The important thing is you recognize and you do not consider that a B line.
Thank you very much, Al. Thank you.
No problems. So that's beautiful. I think some really good cases, and I think a lot of learning. And today I will not torture you. So I will just let Sharif stop sharing, and then I will be hopefully able to finish the session within hopefully half an hour. But it's a very important session. Let's try and close everything down. Don't save because my So I'm going to share my screen 2. Is my screen visible and in full slideshow mode?
Yes.
Yes.
Okay. So basically what we're doing at this particular point is today I'm going to talk a little bit about the Blue Protocol. And the Blue Protocol is a very important aspect of lung ultrasound because it lays the foundations for how we approach lung ultrasound when we want to get information in a short period of time. Now, clearly from our perspective, the Blue Protocol was developed by Dr. Daniel Lichtenstein, who's the father of lung ultrasound, who basically formalized protocols in lung ultrasound in adults, pediatrics, and in neonates. He's done a lot of work on it. But when the Blue Protocol was developed, it was developed as a method of doing rapid lung ultrasound to kind of try and classify the reasons for acute adult respiratory failure on intensive care units. And really what he was able to do is through a study that was performed in 2008 on about 260 patients, where they made a diagnosis clinically and using CT as gold standard, looked at the lung ultrasound profiles of these 260 individuals to try and correlate and see what patterns the different clinical conditions would show. And really what he was able to do is develop 10 signs that you're all very good at doing now, which help to kind of define the nomenclature that we use in adults, pediatrics, and neonates. Now, the most important take-home message from this slide is that whenever you're looking and doing lung ultrasound, it is very important from your perspective that your signs and everything that arises takes its origin from the pleural line. If it doesn't take its origin from the pleural line, as I've just described with a Z line, then that is basically what we call, it's a mimic. And really it's an artifact that should be ignored. But there's certain artifacts that we can't ignore, which are A lines, B lines, and then the progress of B lines. But in particular, having a static structure that basically you can use if you have an acute life-threatening condition is very, very important. And whenever you go through that process of trying to do that ultrasound, you must stick to that protocol. And that protocol is you always start at the pleural line, because everything, including A and B lines, will have their origin at the pleural line. The pleural line will demonstrate sliding or the absence of sliding, which will give you a particular diagnosis. But then deeper kind of areas like consolidation, collapse, atelectasis again also affect the pleural line. Fractal sign affects the pleural line. So eventually what I'd say is it's really important to stick to that structure, and the Blue protocol basically emphasizes this. The first study, as I've told you, was done in 2008. And really what they looked at is lung ultrasound findings in patients with asthma, COPD, pulmonary edema, pulmonary embolism. And all of you will kind of think, well, these are conditions that are not really relevant to neonates. So how is it possible that, there's kind of a Blue protocol that's been developed, and we've actually extrapolated this protocol to actually try and, do lung ultrasounds in neonatology. And I would say that there's very good correlation between the 10 lung ultrasound signs that have been described, the interpretation of lung profiles, and in particular, interpretation of conditions like pneumothorax, pneumonia, pleural effusions. And then I would say, the important thing from our perspective is making sure that we're not missing subtle signs that we can have, which basically correlate with RDS and TTN, which haven't been described in adults, so that we can make a diagnosis for different respiratory syndromes. Now, what I'd say is that when we looked at these adult conditions, there was a very high sensitivity and specificity for the use of lung ultrasound when it was compared to CT. But more importantly, what this basically relies on is scanning 3 areas. And when I say scanning 3 areas, when you look at the neonate, really what we're trying to do is we're trying to scan and partition the lungs so that we're scanning a minimum of 6, sometimes 12 regions. I'd say for, babies under 1,500 grams, use the 6-region approach. For babies over 1,500 grams, you use a 12-region approach where you divide into upper and lower. But that takes a long time. That, from our perspective, in an acute emergency situation where we've got a baby who's deteriorating, means a lot of handling. It also, from our perspective, means that you'll be taking lots of images. And if you start having to do an M mode for every image in that region, it might take such a long time that the baby might go into extremis. And that's why the Blue protocol is highly relevant to neonatology, because the anatomical correlates that have been developed by Daniel Lichtenstein for adults and pediatric patients are just as valid in neonates. And this has been demonstrated in a large study that he's actually performed in 2015, which included neonates on the pediatric intensive care unit and neonatal intensive care unit for a unit in Paris, level 3. So he's validated those findings. Now, what are the 10 signs? And I just want to reassure you, you can do all of them. So the 10 signs that we're expected to know as part of use in a Blue protocol when we do a neonate who has acute respiratory distress are the BAT sign, lung sliding, A lines, B lines, rockets, or what I'd call predominantly an AIS pattern, quad sign, sinusoid sign, fractal sign, tissue sign, and lung point. And if you look at all of them, when you compile this, these 10 signs will basically help to define a lung profile. So normal A profile is a BAT sign with pleural sliding. So if you see that and a seashore sign, that's your A profile, that's normal lung. On the other hand, if you see an A-line profile with horizontal artifact, but with no lung sliding and a visible pleural line, then really what you're saying is that's an A- profile, which will kind of fit with an pneumothorax. You put M mode on and you'll get a barcode. If you have B lines, well, you can't have a pneumothorax if you have B lines or comet tails, vertical artifact, but really B lines with lung sliding, or what we call as a dominant B profile, would fit with a diagnosis of TTN, would fit with a diagnosis of respiratory distress syndrome, but can also fit with diagnosis of evolving chronic lung disease. Mnemonic kind of consolidations with wet lung can also fit with what we call as just simple pulmonary edema, a duct. So again, the presence of B lines with sliding can give you a wide range of differential diagnosis, which can help with classification into kind of a differential diagnosis, depending on when your respiratory distress appeared. And then for a pleural effusion, you kind of have the quad sign and sinusoid sign. Then you come to the kind of mnemonic kind of consolidation. And we all know that, the lung point is part of trying to demonstrate pneumothorax. But if you want to differentiate a consolidation, like a tissue sign with a kind of atelectasis, really the presence of a lung pulse goes in favor of atelectasis, but atelectasis will tend to have static air bronchograms, not dynamic air bronchograms. So again, if you add to this a dynamic air bronchogram and a fractal sign, well, this goes more in favor of a mnemonic consolidation as opposed to atelectasis. So actually, you can see these 10 plus 2 additional signs would be able to give you all your differential diagnosis. And really, what the Blue protocol does is it classifies these profiles based on those 10 signs into approximately 7 profiles. So we've already talked about A, B. C is your consolidation, which we've also discussed. Now, just for your knowledge, the Blue protocol described by Daniel Lichtenstein in adults talks about an A/B profile, which basically means that you'll have a B profile on one side and an A profile on the other. And again, it's a diagnosis that tends to kind of fit with a mnemonic kind of a clinical presentation, or theoretically, from your perspective, maybe atelectasis if you have a B- profile. So really, what I'd say is that this is not a profile that we commonly see in neonates. What we have done is we've replaced this with what we call as an AB profile, which is a mix of the two, which kind of indicates transitioning lung TTN or brings in what we call the double lung point. And then what I'd say is that you have the PLAPS point. Now, we've not previously discussed the PLAPS point, and it is of significance. And the reason for that is it is the third area that you would have a look at if you were doing a lung ultrasound based on the Blue protocol to look at 3 points to make a differential diagnosis in a rapidly deteriorating baby. So instead of doing your 6 regions or your 12 regions of lung partitioning, when a baby is acutely deteriorating, as part of the Blue protocol, you can do 2 points anteriorly, which I will explain how, and the PLAPS point, which is a point which you locate in the posterior axillary line. PLAPS stands for basically posterior lateral alveolar pleural syndrome. And what it basically means that if you want to make a diagnosis of a pneumonia, or you want to make a diagnosis of a pleural effusion, again, both of which will technically be best diagnosed if the baby is supine in posterior regions, and anterior regions can miss pneumonia, then really it's really, really important that you are interrogating the PLAPS point. And this basically forms part of the Blue protocol algorithm, which is used in adults, where they can easily look at all of these kind of profiles to kind of aid specific diagnosis. Not all of these are valid in neonates. Like, we don't really talk a lot about pulmonary embolism, but a B profile with pulmonary edema might be very relevant in a baby who's got a duct, or a VST who's in heart failure, say, for example, or a baby with chronic lung disease who's in heart failure. And again, what is important from your perspective is that you're using this in the context of a baby who is rapidly deteriorating to try and make a diagnosis very quickly. So you're not doing a full 12 or 6 region lung ultrasound. I'm not going to go into too much detail with the slide. It's only to highlight again that the AB profile that's been described by Daniel Lichtenstein is very different from the AB profile that we describe as part of transitioning lung. What is important from your perspective is which points do we need to do as part of the Blue protocol? And how do we determine that? So you can put 2 hands on the front of the chest as described over here. And if you look at your ring finger and middle finger, then the first anterior point is basically at the position of the middle and ring finger. It kind of is infraclavicular, and it basically correlates very much with R1. So if you're looking at R1, and I want to make this as simple for you as possible, so I'm just going to use my laser pointer over here, is I don't want you to lose sleep. So when I say I don't want you to lose sleep, in babies putting 2 hands in a baby who's got a tension pneumothorax and is deteriorating is going to take time. So really, if you're looking at R1, and then you really look at predominantly your R2 region, which is described as being the lower half of the hand, the lower hand. These are your two anterior points. And really what I'd say is it correlates mostly to R2 in the anterior axillary line, just below the level of the nipple. So these are your two anterior points that you're going to scan. And what you're going to do is you're going to look at the profile here and you're going to look for M mode over here. Very important if you're trying to make a diagnosis of an pneumothorax. But then your last point is your PLAPS point. But what really correlates with looking at R3, but you're looking at R3 through the posterior axillary line. Remember, you do not want to move the baby. You know, a baby who's sick, deteriorating, you want to handle them minimally. And this is where I need you, and I need you going forwards now. In this month, I want you to start practicing looking at the posterior part of the lung through the posterior axillary line. So that basically, from my perspective, means that you're holding the probe in the PLAPS point, directed slightly cephaloid. If you're using, now this is a microconvex probe. Okay, this is a microconvex because this is exactly what was used in adults. If you're using a linear probe, you can actually keep a linear probe in the posterior axillary line with the baby supine. So if this is the baby, look at my hand, and this is the axilla. Really keeping a linear probe like this without having to move the baby with good contact, 90 degrees. Remember, abduct the hand, expose the baby. Then really that will tell you what your PLAPS point looks like. You can pick up a pneumonia, you'll pick up a pleural effusion. And when I take the talk on pleural effusion, it is the best way to define where your pleural effusion is maximally concentrated for you to put a needle if you want to do thoracentesis. Now, anybody, I'm going to take a short 2-minute kind of a break for questions here. Is there any confusion about this? The blue protocol.
Sorry, Alok, can you just repeat what you just said about that? What? Sorry, can you just repeat what you just said?
Okay. So the blue protocol is done in 3 points on the right and the left. The way you choose those 3 points in adults and pediatric patients is you put your hands on the front of the chest like you see in the diagram over here. The upper point is basically at the level of the middle and ring finger and roughly falls in the region of what you'd call R1 in a baby. So you can see R1 over here. So really what I'd say to you is that as long as you're doing a longitudinal scan in that region, in the region of R1, you're covering your upper anterior point. The second point that you need to cover is usually the back of the hand, which falls in the level of the nipple, usually in the anterior to mid axillary line. So very similar to how you'd find R2 in a baby, maybe a little bit lateral instead of being completely parallel. So over here. So these are the two anterior regions that you would need to scan. And you would, because you're looking for air, predominantly in this situation in an acutely deteriorating baby, you must do M mode. So these are the two anterior points that you would scan in a hurry. And then really what you need to do is scan the posterior axillary line, the PLAPS point, which is basically towards the back of the chest. Now you're not going to move the baby. So you would have to keep your probe. This is a convex probe, if you can see over here, that's being held transversely. You'll be using a linear probe or a hockey stick. So you would be keeping it directed onto the chest and directing it slightly cephaloid, but actually in the region of the posterior axillary line. And my experience is even if you kept it horizontal, if this is the baby and you kept it horizontal, but you're in the posterior axillary line, it should be okay. What I will do is I'll take a video of it so that we can show you how it's done.
Okay, thank you.
Any other questions? Is anybody confused about the 3 points on the right and left that you'd have to have a look at? I will not move forwards if you. No confusion? Okay. Now, why do we want to do these 3 points? And why do we want to do them quickly in the blue protocol? Well, a common diagnosis, as you've seen, for us is a pneumothorax. And actually, if you do R1 and R2 with a baby supine, similar to that, 2 points, and you clearly don't see any lung sliding. You don't see any B lines. and you're able to demonstrate a lung point with a barcode sign, then you know there's a pneumothorax there. On the other hand, today we've seen lots of videos where actually you can see comet tails and B lines. Now, if you've got B lines, but you can't see lung sliding, that might be a B profile with minimal to absent lung sliding. Now, that could be atelectasis with absent lung sliding, but it cannot be a pneumothorax. And what I'd say is that, really what you want to be able to do is demonstrate the lung point and have a barcode sign as a bare minimum. So a good example here is we're doing anterior lung points that we've just demonstrated. You see pleural sliding with an A profile, that's normal. But if you see B profile, and it's really, can you see sliding confidently on the slide on the right? Anybody? What do you think? What do you think about sliding here? Kirti?
Present.
You think it's present?
No.
Not sliding.
See B lines.
See some comet tails.
Yeah, very good. Very good, Dr. Leila. Beautiful. So my view is that if you look at the right in particular, I just cannot confidently say there's sliding. But you cannot have a pneumothorax because you have comet tails and you have B lines. I think this is a very important take-home message, that if you have B lines, and I mean, here you have compact B lines with basically what looks like a double lung point, you can't have a pneumothorax, even if you don't have sliding. This, I mean, because you have a double lung point, goes more in favor of transitioning lung disease. And maybe the baby is breathing a little bit shallow. So what I'd say is that you make the baby cry to make the sliding more prominent. But when you come to this image at the bottom, anybody, can you see lung sliding?
No.
No, classical truck sign. I mean, you've got a very decent pneumothorax, 1, 2, 3, 4, nearly 5 intercostal spaces. This is right anterior, all the way from bottom to top. I mean, this was a massive pneumothorax in a baby with a diaphragmatic hernia, who we basically put needled and put a chest drain in. So again, you can make a very rapid diagnosis of a pneumothorax without having to do all 6 and 12 regions in a baby that's acutely deteriorating. Now they will be presenting the safe and the safer protocol, but today, towards the end of the lecture, I'm going to tell you how to do a very rapid ultrasound in a deteriorating baby. We've already talked about this in the adult. The question from our perspective is what and how should we make these diagnoses using a diagnostic algorithm? So the first step from our perspective is you have an acute situation with a patient or a baby that's acutely hypoxemic. So your first step would be to do your upper anterior blue point and your lower anterior blue points that we discussed, which are technically correlate with R1 and R2 in those regions. And really what you want to see is, can you see lung sliding? Because if it's present and you have a dominant B profile with wet lungs, that goes more in favor of pulmonary edema. But if you have consolidation or a C profile, that goes more in favor of pneumonia. If the lung sliding is absent in these two areas, then really what you've got is you've got a possible pneumothorax anteriorly, you've got an A profile, you've got a lung point, that means that you have a pneumothorax. If you have no lung point, for me, you probably either have a very big pneumothorax. So this bit about it, and this is, I'd neglect that. I'm not sure that's really valid for neonates. And that's where I would say that what we really need to do is we need to adapt the blue protocol to the neonate. And that has been very, very well described by Curipa. I will share 5 articles with you today after the talk is over. And really what I will be talking to you about is how we apply the blue protocol in neonates using Dr. Curipa's kind of protocols. Now, for us, there are kind of 4 syndromes that I'll be sharing guidelines with you about. So the first one is the baby who presents with acute respiratory distress after birth or in the immediate postnatal period. And you'll see that Dr. Merchant and other colleagues have kind of presented, Sujit has presented today, some really nice images of babies who presented with respiratory distress immediately after birth or in the immediate postnatal period. The differential diagnosis for that will be different from late onset neonatal respiratory distress, which occurs later on, which might be different from the acute collapse on the ventilator, which will be very different from the baby with acute RDS, who say has surfactant and is deteriorating, or a baby, say, for example, who has RDS, who's deteriorating very acutely because he's got very severe RDS and pulmonary hypertension. And really, this clinical presentation will really govern what differentials you consider. But using the PLAPS point, as well as the two anterior kind of points, you can actually make these diagnoses very, very quickly. What is very important is that you have examined the baby, decided on your clinical presentation, and then basically from our perspective, stabilize the baby. So really what I'd say is you've got a baby with an anterior pneumothorax, which is tensioning. That's not a diagnosis that you can really wait for a chest X-ray. It's going to take time, but even lung ultrasound will take time. If it's clearly transluminating, you're clinically confident that's the diagnosis. You're going to needle on clinical grounds. But for the semi kind of deteriorating babies who are saturating, who have pulses, you really want to do a lung ultrasound if that's quicker than doing a chest X-ray. And then obviously, depending on your level of confidence, you'll decide on a management decision. But the Blue protocol basically says that you can do all of this by looking at the anterior 2 points and the PLAPS point. And really, if you've got anterior air and at the PLAPS point, you see that there is clearly lung sliding. There is clearly B lines with kind of A lines. Then really your pneumothorax is not extending beyond the posterior axillary line. Your baby has pulses. Your baby basically has perfusion. Well, really, there's time enough here to do an X-ray to really determine if your gas is reasonable, that actually this baby might not necessarily need any treatment and can be managed conservatively. On the other hand, if there's marked respiratory distress and you can see, even in the posterior axillary line that you've got no lung sliding with an A dash profile with kind of a barcode sign, that's a big pneumothorax, and clinically that might not be able to wait for a chest X-ray. If you're transluminating clinically, I think needle would be the way forwards if that clinically correlates. So can you see how without doing a 6 or a 12 region kind of a scan, you can rapidly make a diagnosis in a rapidly deteriorating baby using this protocol, which is validated in neonates. Now, what this does is this makes this algorithm much simpler. Because if you try to use this algorithm in real time, God help you, because actually mental modeling can take time. And this is where I would say to you that really from your perspective, what you have to do is adapt the Blue protocol. So this is the protocol that Curipa has developed to kind of make a diagnosis of differentials for babies who have immediate postnatal respiratory distress. And it basically works down an algorithm which kind of establishes all these diagnoses by establishing the profiles based on those 10 lung sounds. But those 10 lung signs really, you can already do them. And if I wanted to make this easier, a simple kind of approach that I would take, well, look, I've got a baby who's got respiratory distress in the immediate postnatal period. This baby is kind of got significant oxygen requirement, is 50% oxygen, but he's not crashing and burning. I can feel pulses. So this is definitely clinically, from my perspective, a situation where I've got time to be able to do a lung ultrasound. Now, depending on my examination, for me, I want to go to the point of interest first. And really what I'm looking to make a diagnosis of is something that I can treat, something that's reversible. So I'm going to do the anterior 2 lung points first and the posterior lung point of the Blue protocol in that order. But I'm going to do it in the region of point of interest. And that's important. What that means is that if I auscultated this baby and there was reduced right-sided air entry and it transluminated on the right side, I would not be starting my lung ultrasound on the left. Go for the right side first. So start with your point of interest first. Very important. But if you look at the differentials that I'm going to keep for this baby, I'm not really going to make a diagnosis of chronic lung disease at this particular point, nor am I going to kind of think of acute atelectasis in a baby who's not been tubed. Really, these are the common differentials that I'm going to think of. And if I do these 3 points, I should be able to make these diagnoses relatively quickly. Undiagnosed hydrops will be, if it's bilateral pleural effusions, you won't even need to go to, the anterior lung point might not give you the diagnosis, but the R2 and the PLAPS point will give you the diagnosis of a massive pleural effusion. And really, if you're starting to stick needles in theater, there you're treating on clinical grounds. But before putting a chest drain in, there's absolutely no doubt. I always try to look at the area with the largest pocket. What I'd say is you then decide on the management decision. And for me, what is important is that really once I've made a diagnosis and I've decided on a management strategy based on my lung ultrasound, clinically, if my baby is not improving, I'm going to go back, clinically assess, probably repeat my lung ultrasound. But if there's any confusion, or I've got a colleague who doesn't do lung ultrasound, please confirm with a chest X-ray. Use it as an adjunctive diagnosis. If you've not developed the confidence yet to apply the BRU protocol in neonates and make management decisions based on that, get 2 colleagues to review if you can. Another consultant to come and have a look at those 2 points and say, okay, I'm going to do a BRU protocol kind of lung ultrasound for a pneumothorax. Are you happy just to stand next to me and we can both have a look at it together? The question is, how do you do it? Now, I use a kind of an approach which is called the pit stop approach. Now, what is the pit stop approach? So the pit stop approach basically means that if you have an acute deterioration in a baby who's got a pneumothorax in delivery suite, you kind of gonna manage that baby clinically. I would have expected that if that is the case, you put a crash call out, and in our situation, at least where I've worked in systems, it's a 4-member team for a situation like that. This baby is definitely going to need airway breathing management, might need circulatory access kind of management, will need an experienced nurse, somebody to help with equipment, and somebody who basically has global overview or the helicopter view. Now, in that situation, if time permits, you've decided to intubate, ventilate, the baby's not crashing and burning, baby comes to the neonatal unit, and you're waiting for a chest X-ray, and you decide to do a lung ultrasound. You still need to do things in parallel. And this is what the pit stop approach is all about. It's not as if things stop. So, okay, I'm doing a lung ultrasound until such time, nobody prepares for the access. Well, what if you've got a pneumothorax that's gradually evolving into a tension pneumothorax? So actually, while I'm doing the lung ultrasound, somebody, the airway 2 person who's going to do breathing, or who is preparing a needle with a 3-way tap and a 20 ml syringe. I kid you not. You know how people will come back to you with 5 or 3 ml syringes. That's useless if you've got a tension pneumothorax. So really, human factors would say that while you're doing this ultrasound, the safer approach in the acutely collapsed baby, people need to be preparing in the background. And I would say that for doing an ultrasound in situations like this, you really need to have members of your team who are capable and happy managing the airway. If you're kind of in a situation where you've got tamponade, that's the issue. Really, you probably will be in the situation where this baby is hypertensive collapsing. Now, somebody might be doing compressions. And the question from your perspective is how you get the probe on without interfering with resuscitation. We will talk a lot about that when we do the Safe and Safer R protocol. But my experience is that if you're doing a lung ultrasound on your own with no preparation and you're making a diagnosis of a big pneumothorax and no preparation is done, you're losing time and you're delaying management. So really what I'd say is think about that approach and how you are going to do the ultrasound, but how you're going to use other members of the team to rapidly intervene if you have a big pneumothorax. You might have a baby with very severe meconium aspiration who's aspirated in utero, who's not saturating. And really you do your lung ultrasound, you make and you think, well, there's no pneumothorax. There is bilateral kind of consolidation, patchy. But really the problem over here is you're not saturating. Well, surfactant is something. It's something that you can prepare. And again, the question from our perspective is how you're using your team with closed loop communication to kind of prioritize access, surfactant, antibiotics, doing a gas, getting a chest X-ray. That's a lot of work that's happening while you're doing the lung ultrasound. And that's why I strongly recommend that you think of how you organize your teams and having these things happening in parallel. You might want to prioritize antibiotics first, followed by surfactant, or you might want to prioritize giving surfactant first, depending on how hypoxic the baby is. If you're making that diagnosis, some people don't like doing surfactant in meconium aspiration. It obstructs the airway. Again, it's the mental modeling and sharing kind of your approach. But if you have bad MAS, this baby, maybe an hour or two down the line, after surfactant might not be improving. You have difference between pre and post-ductal SATs. You might have to do an echo. So the question is, well, did you have enough time to do the echo the first time around? And we'll talk about that. But can you see how when you're applying the BRU protocol or even the Safe or Safer R protocol, You need to have a structured approach, and you need to have enough team members. I think if you're on your own trying to do an ultrasound, not sorting the airway out, the baby's accidentally extubated and becoming bradycardic, you don't know where the tube is, and you're doing a lung ultrasound, you're in trouble. Similarly, you've got the late onset neonatal respiratory distress protocol that Curipa has made. This is a little bit easier. These are babies who are usually not crashing and burning, but there could be babies where the FiO2 is going up. You're kind of struggling with ventilation, and you have to make, kind of changes based on that. And a really good example is what Kirti showed us today. Beautiful, not a significant amount of time to do. Now, my experience with this part of the algorithm is, I think for me, the blue protocol is not good enough. And I would say that if you have time, please, in the extremely small babies, look at all lung regions, especially if you don't want to miss pneumonia and atelectasis and you want to recruit these areas. Again, if you want to score BPD. So for me, the blue protocol in this context will probably be insufficient. It might tell you that you've got a massive pleural effusion in a baby with high drops that's getting worse. And a good example is you've got a baby who you've kind of tapped, removed the chest drain, started feeds, and he started to develop a chylus kind of pleural effusion, which the respiratory distress is gradually going up with. So you might be able to pick that up. But I think if you had focal consolidation, mnemonic kind of picture in the posterior parts of the lungs, you'll miss that. So for the late onset respiratory distress, I expect a full scan. Again, the approach here is it depends on how quickly the baby is deteriorating, but the differentials will be different. Your approach should always be, if you decide that you're using the blue protocol in a baby where you think there's an acute issue that you're going to need to treat because this baby is getting sick, is to have a team approach and think of what you have to do in parallel while you're actually doing the ultrasound, while the decision is being made. Any questions about that? Okay, so let's go to a case. Who wants to have a go, guys? Anybody? Any volunteers? It's a nice. Okay, who's that?
Layla.
Okay.
Go ahead.
Go on, Layla.
Okay, so Layla needs a partner in crime. Who's going to help Layla?
I can team up with Layla.
Beautiful. Okay, so it's Dr. Zaruddin. So I've got a baby who was basically antenatally diagnosed to really have severe oligohydramnios from about 16 weeks of gestation. Always the concern that this baby might have lung hypoplasia. And I think the overall feeling was this baby had very severe hydrocephalus as well, that the baby would probably die in utero. But at about term, this baby was about 3 kilos. And with this kind of clinical presentation, mom went into labor, the baby delivered. The baby, we could not saturate after birth, so had full resuscitation, ended up having intubation, came to the neonatal unit, still could not saturate. So we kind of in a situation where we had SATs of about 60, a heart rate of about 130. The gas is a pH of 6.9. The CO2 is in the range of about 100 millimeters of mercury, which is technically the equivalent of about 14, 15 kPa. We're quite hypoxic, and we obviously transluminated. There were concerns with regards to an evolving pneumothorax. So this baby basically had needle aspiration and a drain, but the right side of the lung showed an RDS-like picture. So the saturations picked up, and at about 2.5 hours of age, they dropped again, this time to the low 40s. Heart rate's about 110 to 120. We haven't had time to repeat a gas. This baby's already had an X-ray, and the X-ray lady has gone back downstairs. You've put a drain in, you've re-X-rayed the drain. Obviously, from our perspective, has not been X-rayed. We've called her, but this baby is rapidly deteriorating. So, what would we like to do?
So the baby is unstable.
Yeah.
Very important that the clinically stabilize the baby.
Yeah.
Here, I'll just make sure, airway, airway, breathing, circulation is being maintained. If he needs boluses or inotropes or INO, or thinking of pulmonary hypertension, or maybe go to high frequency ventilation. So that'll be my first priority to just stabilize the baby.
Beautiful. So what you've done is you've had a look. The tube's in good position. It's actually a little bit on the high side. So, for a 3-kilo baby, this tube is actually about 8 at the lips, just under 8. But you've got air entry with a little bit of chest wall movement. You've auscultated again. And really what you've noticed is, the drain obviously initially went in on the left side. So you have left-sided air entry, which is better. You've got very faint heart sounds. And really from our perspective, you've got reduced right-sided air entry. So you've oscillated. You've decided that you're going to move towards the oscillator. So, yep.
So I'm still worrying about pneumothorax, especially in the right side, you're saying, right?
Okay, so you're going to do a blue protocol lapse point.
That's what you want to say.
Yep. So what you've got is the blue protocol, which is the right upper. This is the right lower. As you can see, the liver is coming through. I'm using a linear probe with a frequency of about 8. And then what I've done is I've done the posterolateral area very quickly. So I've done basically what is classical blue protocol on the right side. So what do we think?
So I start with the right upper. There is no, I could see four intercostal spaces and 3 ribs. There's no sliding. I cannot see sliding, and I see a profile. So I would like to put my M mode to make sure there's no pneumothorax there.
Yeah. So M mode gives you a barcode sign, very classical barcode sign, which I haven't. Yeah. Okay. So now you come to the right lower zone. What about the right lower point?
So I still don't see the lung point. I might be seeing some sliding near the liver. But mostly there's no sliding, and it's a profile.
Okay. Dr. Zahiruddin, what do you think? So we're mental modeling here. So do you want to look at R1 and R2?
I agree with Dr. Layla's findings, of course, but still on the lower right, there is I'm not sure if the very right end of the pleural sliding or non-sliding is interrupted closer to the liver on the right side.
Yeah. So you've got thymus over here.
Yeah.
Okay. Now that's obviously the upper ribs, 1, 2, 3, 4, nearly 5th. And then you have 6, 7, 8, 9, kind of lower down you have the liver. So you've got virtually no sliding there, and you've just got a little bit of lung pulse over here. So is my feeling. But classical barcode signs, so that's quite a large area of air.
Yes.
If you've got a barcode sign there. And then I do the PLAPS point. What do I see? So when I do the right posterior. So Dr. Layla, go for it.
So again, now I see a lung point here maybe, but there's no sliding in the left side, and it's a profile mostly. And then in the right side, there may be just a beginning of a lung point and some sliding.
Very good. That's beautiful. That's beautiful. Can you see the lung sliding here, guys? Is anybody confused? You can see an actual comet tail coming through here. I'm unfortunately losing the top of my image because of the lack of alignment. And, this baby unfortunately was not paralyzed at this particular point of time, but I make this the lung point. And if this is the posterior axillary line, which is where I am, this is a very big pneumothorax. Okay. So very quickly, I do the left side, which has already been drained. Remember, it's already been drained. It's got a drain. Clinically, this drain is swinging and bubbling furiously. Okay? Swinging and bubbling furiously.
Okay.
Oh, please don't hang. Sorry, my apologies. I'm showing you the right again.
Residual pneumothorax in the upper left.
Yep. So this is the left anterior. This is the left lower anterior. This is the posterior.
No sliding in the middle portion. And I could see sliding in the other side. So maybe residual pneumothorax over there.
Yep.
Same in the lower left. Or maybe just a lung pulse here. Oh, sorry. Oh,
yep.
This is the heart, right? This is the heart.
Yeah. So you're right. This is the heart.
Yeah. So there's no sliding, an A profile.
Okay. So you're absolutely right. There's basically what you see is a lung pulse, because actually when I put the M mode on, I had a classical barcode sign. So really, this is not sliding. This is lung pulse because I have a barcode sign. So I've got anterior air still, and this is the posterior part on the left.
Okay. Yeah, you could see comatales, and you could see some B lines. So there's normal sliding here and no pneumothorax.
So there's an anterior kind of collection of air at this particular point. So really, where's your needle going to go and where's your drain going to go on the right side? But I mean, this entire scan has taken me, it's taken me 90 seconds to do the scan. More time to get the machine, but just 90 seconds to do the scan. Quick images with M modes. And really, it's given me so much information. I'm not waiting for another X-ray. The right side needs a chest drain. It gets needled and the baby gets a chest drain. Now, as part of the scan, obviously, while we're waiting for the needle to happen, there's some images that you can do very quickly. And really, what I'm looking at is the ET was high. Now, from my perspective, this ET, actually, it's here. Can you see it there? It should be 1 centimeter from the arch of the aorta. Actually, it's high. It's more than 1 centimeter. It was about 1.5. So can you see that there?
Oh, I see. Okay.
That's the endotracheal tube. So it should be 1 centimeter above the arch of the aorta. It's actually high. And I mean, a simple thing. I've just done 2 views to kind of see what the duct is doing. And we have severe pulmonary hypertension. You know, you've got a TR gradient of about 4. The duct is basically all right to left. And you've got a PFO which is completely right to left. So really, from my perspective, we drained the pneumothorax and then we kind of repeated. And really what we had is bidirectional ductal flow. So all this pulmonary hypertension that we see at this particular point got reversed after drainage of the pneumothorax. So this is predominantly because you've got bad pneumothoraces, that you've got a clinical picture like that. And, you know, the 4-chamber view, the heart is really poorly filled, basically because you've got a pneumothorax. But you can do this very, very quickly. And this is where I'd say, this is how you implement and do ultrasounds in rapidly deteriorating babies using the Blue protocol.
Excellent, beautiful.
Any questions?
Thank you.
So again, it's to emphasize, whilst I was doing this ultrasound, somebody was preparing a needle, because the index of suspicion was very high. Whilst, you know, I think the important thing from my perspective is really it's about the multidisciplinary approach of preparing for what you think your most likely differential is. Now, clearly, if this is pulmonary hypertension in a term baby, and I don't have a pneumothorax and I'm not saturating with a different pre and post ductal SATs difference of about 10%, then really it's nitric. Even nitric and drawing it up can take a long time. So, you know, when I was in Southampton, used to take our nurses about 30 minutes to kind of run the nitric through, test it, do all of those things. So again, the parallel planning around these things is very, very important. I finished there. Does anybody have any questions? Today we finish on time, 5 minutes ahead of time.
Look, can I ask a question, please? You know, in the with the Blue protocol and the definition of the points where you do your scanning. You know, in a small baby, we usually sweep, right? I mean, we start in R1 and we go down, and then R2 and we go down, and it's really small chest. Is it very important to define these points?
That's the point I'm making. That actually, really, if you did R1, R2, and you did technically, so I'll just take you back to that. So if you kind of do R1, R2, and really what you're doing is R3 in the posterior axillary line, the PLAPS point over here. But remember, they're using a convex probe. You're using a linear probe. So actually, if you just held the linear probe at 90 degrees to be able to give you that point, you're really doing R1, R2, and the back of R3, maybe R4. If you're kind of looking at so don't, I don't go putting my hands on the chest for those points. That is for adults where there's a huge surface area. For the neonates, you're doing these 3 points. But again, you're doing them rapidly. And for R1, R2, don't forget to use your M modes, guys. Very, very important. It takes a second. Any other questions?
Alok, it's Sujit. Yeah. I just had a question about distinguishing your thymus from consolidation.
Yeah.
Would you use sort of your starry sky appearances and those sort of vascularity, or generally?
You can do. I mean, what I'd say from my perspective is that clinically, I've got a high tube. And this is quite high up. Again, I'm clinically correlating. What is likely? You've got, you could argue that that's atelectasis. That's a right upper lobe collapse consolidation. But experience says that even if it is, really what I want to do is treat the pneumothorax. I mean, we repeated the X-ray and it wasn't. So retrospectively, I think if you're confused, don't feel too worried about it, but definitely go back and look at your tube position. Because if it's low, pull it back, please. And it can be very confusing. It can be very, very confusing. We'll be seeing lots of cases.
All right. Thank you.
My pleasure. Any other questions? I'm really grateful for everybody's patience. God bless you. And more practice. So please, going on from now, what I'd like us to do is continue practicing. But just remember, by the end of this month, we will stop talking about the abnormal lung. And really what I'd like to do is then move to the diaphragm, please. We want to practice diaphragm in our last month. That's quite crucial. So please, lots of practice. We have all of the sessions will have 45 minutes of peer review, including on Tuesday. God bless you all. Have a good evening. Take care.
Thank you.
Thank you, Alok.
Thank you. Bye.
Thank you.